I want to go to our next speaker, who is Dr. Mark Pomerantz. And Dr. Pomerantz, I'm going to ask you to unmute. There you are. Okay, we see you fine. Thank you. Now let me introduce Dr. Pomerantz. First, before I give you all of his background, I would like to let you know that he is my doctor. So and I can vouch that he's a very good clinician. But Dr. Pomerantz is a medical oncologist at the Dana-Farber Cancer Institute in the Link Center for Genitourinary Oncology. And he is an assistant professor of medicine at the Harvard Medical School. Dr. Pomerantz received his undergraduate degree from Yale University and his medical degree from Stanford University. He trained in internal medicine at Brigham and Women's Hospital in Boston. He then pursued a fellowship in medical oncology at the Dana-Farber Cancer Institute. Dr. Pomerantz received his postdoctoral training in cancer genetics at the Dana-Farber Cancer Institute and Broad Institute of Harvard and MIT. Dr. Pomerantz.
Okay, so I'm going to share my screen so we can see my talk. And then I'll put this up. Thank you very, very much for the introduction and for the opportunity to talk to this group. It is always an honor to talk with you all, and I very much welcome any questions. I'm going to focus on the treatments and approach to later stage prostate cancers, to prostate cancers that have metastasized. And maybe we'll jump right in to make sure there's enough time for questions. We'll kind of focus in on a case, a 61-year-old African-American gentleman who had his radical prostatectomy in 2015 with some aggressiveness under the microscope at pathology. Unfortunately, the surgery was not curative, and the PSA was increasing after surgery. He was treated with hormonal therapy, androgen deprivation therapy, with very good response, and was able to receive intermittent hormonal therapy, intermittent androgen deprivation therapy for a few years, meaning that he started it when the PSA went down to a nice low number. He was given a break, and when the PSA started going up again in a way that he and his doctor didn't like, he restarted the hormonal therapy. However, these vacations with intermittent therapy only last so long, and he required continuous treatment. And by this year, his PSA started increasing even though he was on hormonal therapy. And that's where we'll leave off with this patient and ask, what do we do at this point? What do we do with prostate cancer that has proven resistant to first-line hormonal therapy? It's a very, very common situation. And I'm going to provide model for looking at it at the issue here. So we'll focus on this graph because I'm going to have this picture up, I think, for the entire talk. On the y-axis is the patient's PSA level as it rises and falls on treatment. And on the x-axis is time. And the disease progresses from non-metastatic, as we're starting out at the end of the list of events in the current patient. But eventually, the disease metastasizes and later actually may cause symptoms. What varies dramatically among prostate cancer patients in this tough situation is the meaning of time. For some patients, tragically, this timeline is fairly short. And oh, is Brent, one of your, I think that one of your Zooms is not muted. Okay. Thanks. For some patients, this is very short. And for some patients, it's very, very long. And that does vary. And again, that it really does vary from patient to patient. And I'm happy to talk about how we can predict who has the long timeline and who has a short timeline. But the pattern is pretty much the same. In this patient, he was able to receive intermittent hormonal therapy. His PSA went up after surgery. He received androgen deprivation therapy. PSA went down, he took a break, it went up again, he started it again, it went down. But when he started it the last time, it kept going up and he required other treatments. Below, in these different colors, are the different types of treatments that are now FDA approved for prostate cancer as of this year. And I'm going to quickly, because we don't have a ton of time, go through each of these forms of treatment that we now use in 2020, talk a little bit about when we use them and why we use them, and what we're learning about African Americans in particular in response to these medicines. So first, and usually the first medicine we reach for are these fancy new AR-targeted therapies, other forms of hormonal therapy. And there are now 4 that are FDA approved: abiraterone, enzalutamide, apalutamide, and the most recently FDA approved darolutamide. These are a real breakthrough because the side effect profile compared to older types of medicines such as chemotherapy are much, much better generally. And they've been so effective that they're now approved not just for men with metastatic resistant disease, but also now in the non-metastatic setting, men whose PSA is going up on hormonal therapy, but the scans are negative. And we'll talk about that now. Just to give you some sense of how these work, this one is about the mechanism of action of enzalutamide. These take advantage of prostate cancer's escape mechanism. As many of you know, and as many of you have learned by going through this ordeal, prostate cancer is addicted to testosterone. That's what the T represents in this picture. But more specifically, prostate cancer is addicted to activation by testosterone's target, the androgen receptor. When the androgen receptor binds testosterone, it's able to cross into the nucleus where the DNA is and bind the DNA. And that really is the key in the ignition, is when the androgen receptor binds to the DNA. And it needs testosterone to do that. When we give hormonal therapy as the first-line treatment, we are very crudely not really doing anything to the androgen receptor. We're just trying to deny it the testosterone. We're trying to turn off the testosterone. But we can't turn it off completely with hormonal therapy. The cancer cell figures out nefarious new ways of getting that androgen receptor turned on and binding that DNA and doing its dirty work. And these fancy new medicines, these 4 that I listed with the complicated names, they are new ways of keeping the androgen receptor from getting into the nucleus and binding the DNA. Enzalutamide prevents the testosterone from binding directly, and then it also prevents the androgen receptor from being able to cross this membrane. It's a very, very effective drug, and it's the way that many of these drugs work. Abiraterone, another of these, also prevents the production of any testosterone, not just from the testicle, but from other parts of the body. And so these sophisticated new drugs really attack the prostate cancer where it is most vulnerable. And I want to touch on the most recent because some of you may be unfamiliar with it. It's called darolutamide. And last year in the New England Journal, the big randomized trial where patients were randomized 2-to-1 to receive darolutamide or placebo in patients in exactly our patient's situation in this case, whose PSA is going up before the onset of visible metastases. And this is the space where darolutamide is FDA approved. In comparing the prostate cancer specific survival in patients receiving darolutamide and those receiving placebo, as the months went by, the patients who received the darolutamide in this situation clearly did better. This is actually metastasis-free survival, was much, much longer in the patients receiving darolutamide compared to placebo. But what is unique about darolutamide compared to the other medicines in this category of AR-targeted therapy is that compared to the placebo, there wasn't very much additional fatigue. Darolutamide, the way that this drug was designed, unlike the other ones that you may have heard of, the older medicines like enzalutamide, it does not cross the blood-brain barrier. So while it is affecting the cells that we want it to affect, the prostate cancer cells that may be anywhere in the body, but usually in lymph nodes or in bone or the old prostate bed itself, this medicine does not go into the brain. And so a lot of the side effects that are associated with hormonal type therapies seem to be a little bit less with this drug. So it is a drug that we are reaching for more and more often because our patients find that it's a much easier drug to handle. And I just want to mention it because it is the newest one. I also want to mention what we're learning about these medicines, this category of medicine in African American men in particular. This is an important prospective study centered at Duke University that is being periodically updated. And this was one of the most recent updates in following African American men versus European American men receiving another very common drug in this category, abiraterone. The punchline was that PSA declines and median survival without PSA progression were a little bit longer in African American patients who were matched to the European American patients. As touched upon by Dr. Rose, the responses when you match African American men and European American men to our treatments are generally equivalent. In this case, it actually favored the African American group. So many of the disparities are, at least for this prostate cancer population, may be systemic and not related to response to therapy based on ancestry. And the same is true for Asian American men in similar studies, though the numbers were not as high as in this study. I'm going to move on to chemotherapy, our older form of treatment in this setting. We generally reserve chemotherapy for patients with visible metastases or cancers that look very, very dangerous or invading organs beyond just the lymph node and bone, and we're worried that hormonal type treatments may not be enough. There are two medicines, docetaxel, which has been around now for prostate cancer for over 15 years, and a second-line medicine, cabazitaxel, that is FDA approved for patients who are resistant to docetaxel. And there's a third, even older chemotherapy drug called mitoxantrone that is associated with improvement of symptoms, but not overall survival the way the other two chemotherapy drugs are. Docetaxel and cabazitaxel seem to work equally well. There was a study we were very interested in seeing the results of that were presented last year, where patients were randomized to receive docetaxel first or cabazitaxel first to see if maybe receiving the newer medicine up front would be associated with improved outcomes, but it really wasn't. It really doesn't matter how these are ordered. And currently docetaxel is FDA approved as first line and cabazitaxel as second line. Similar to the abiraterone study in African American men, there have been retrospective looks at how patients do on docetaxel based on ancestry. And there have been a number of big phase 3 trials amounting to over 8,800 patients who received docetaxel. And this group, actually, many of the same researchers from Duke, looked at how different ancestral groups within this group of 8,800 did on docetaxel. And again, similar to abiraterone, response rates when you match patients across ancestral groups, but match them based on the state of their disease, response rates are very, very comparable. And again, when patients were matched closely for other illnesses, the survival benefit from docetaxel was actually a little bit better among African American men. Okay, I'm going to quickly talk about immunotherapy. We have one immunotherapy drug, its brand name is Provenge, that is associated with improved survival, though it has not proven as effective in shrinking tumors, decreasing PSA, and turning metastatic disease around quickly. But it is associated with improved survival, so we do like to sneak it in when there is a break in the action. A popular place for us to use it is if a patient is receiving chemotherapy for metastatic disease, but needs a break from chemo, and during that break, we might add the Provenge. But since Provenge was FDA approved for prostate cancer, much more aggressive and potent immunotherapy drugs have been developed across many, many different cancers. The most common class of immunotherapy drug that you may have heard of because it's so widely used in other cancers like melanoma and kidney cancer and lung cancer and bladder cancer, are called checkpoint inhibitors, taking the brakes off of the immune system. Taking the brakes off and letting the immune system go bananas and hope that the immune system recognizes the cancer cell as foreign has been an enormous breakthrough for other cancers. And the hope was it would be a similar breakthrough in prostate cancer. Unfortunately, as you can tell just by very quickly looking at survival curves of patients who received one of these checkpoint inhibitors or received placebo, they have not produced the impressive results we've seen in other cancers. Ipilimumab was the one I just showed, another drug that's potent in other diseases. Pembrolizumab was given to metastatic castration-resistant prostate cancer patients, and the response rates were very, very modest and were disappointing as we were conducting the study and seeing so few responses. However, the patients that do respond tend to have pretty impressive responses. So while the response rate is low, the depth of response among the responders is very, very high, or the depth is very good. And we're trying to figure out who those patients are. We do have some sense. There are certain genetic mutations that are more common in colon cancer, but do happen in a small percentage, maybe 3 to 5% of prostate cancer patients. And patients that have that mutation may be those great responders. And in fact, the FDA has approved these checkpoint inhibitors, these potent new immunotherapy drugs for prostate cancer patients or any cancer patients that have these very specific genetic mutations. This is one argument for taking a look at the genetics of a metastatic tumor. There's another reason to take a look at the genetics of a metastatic tumor, because there's the last class of drugs, which I will get to in a second, in purple below, the PARP inhibitors also require genetic testing. But it looks like I snuck in the radiopharmaceuticals next. Radium-223 is, has been around now for a few years. It's a molecule that goes to bone, and connected to that molecule is a little packet of radiation. And since bone is a very, very common place for prostate cancer to go, this is an injection that we can give to our prostate cancer patients to treat bone metastasis. But it's limited to bone metastasis. This molecule does not go to soft tissue or anything but bone. So we generally avoid it for patients who have any disease beyond the bone, like in the lymph node, for example, which is a very common place for prostate cancer to go. The radiopharmaceutical friends of ours are working on this. And there is an exciting new drug that I'll mention here, because we will all be hearing about this if we haven't already, called lutetium-177. And this similarly is a molecule, an antibody, that doesn't go just to bone. It goes to any cell carrying this marker that is unique to prostate tissue and is on the surface of most prostate tumors. And when this antibody binds this prostate marker, it releases the radioactive particle and gives a little dose of radiation to all of the prostate cells that it binds to. And in early trials, very, very impressive responses, like you see down here on the bottom right, have been observed. The first results of a very important study based in Australia was discussed at a recent conference of ours, where patients were randomized to this radiopharmaceutical or cabazitaxel when they became resistant to docetaxel. And the response rates were higher in the patients receiving this milder, easier to tolerate form of therapy. It is now available in Germany and Australia, and it's a matter of time, especially as this study matures, before we will have access to it here. At Dana-Farber, we had access to it as part of a clinical trial, but we now await its availability to prescribe to patients. Like radium-223, they are monthly injections times about 6, so 6 months of treatment. Okay, and then finally, the newest drugs to be FDA approved are the PARP inhibitors. These are medicines that target a very specific mutation that happens to a percentage of prostate cancer patients. Specifically, mutations to our DNA repair system. And the genes that are most commonly mutated are BRCA2 and BRCA1. BRCA2 the most in prostate cancer. In breast and ovarian cancer, it's both of these. In prostate cancer, this gene is mutated in about 20 to 25% of metastatic prostate cancer patients. And these drugs, called the PARP inhibitors, take advantage of the vulnerability created by a mutation in these genes. And if your tumor has a mutation in genes in this pathway, these drugs can really do a very good job of arresting the prostate cancer in its place. And this was the PROfound trial that was recently published, showing the pretty high benefit that patients can get from these medicines, which again, like some of the other newer medicines, like the hormonal therapy, the radiopharmaceuticals, even the immunotherapy, can be very, very well tolerated relative to chemotherapy. But it does appear that you need to have a mutation in a particular gene. Again, BRCA2 is the most common. This is another PARP inhibitor that has been FDA approved now in prostate cancer, called rucaparib. And patients, this plot shows PSA responses for every patient in the trial. Each column is a patient. Some of the patients inherited the defect in BRCA2. Most of these patients are BRCA2 patients. And, but a higher percentage evolved the mutation in their tumor. In order to find out, though, if you're a patient who could benefit from one of these new drugs, you do need genetic testing. And most likely genetic testing of a metastatic tumor, which is no small thing. It is a procedure to have a needle put into a tumor and then sent for sequencing. That does take time. But if there is a mutation in the gene, this is yet another new option for patients with metastatic disease. I'm going to simplify this chart. What has been unknown is whether African American men carry mutations in these genes at any high prevalence. We know that other groups, other ancestral groups, particularly people with ancestry from the Mediterranean, so Ashkenazi Jewish groups, Italian, Greek patients, do have a higher prevalence of mutations in this pathway. This was a study where the company Invitae that does some of this type of genetic testing looked at all of the patients who had sent blood in for genetic testing to look at the rates in African American men. And let's see, oh, there we have it here. So while the rate of mutation in these genes was 4.8% in all men tested, it was 2.8% in African American men. So it does appear to be a little bit lower in African American men, but it is there, and it is a consideration when thinking about the next treatment. If an African American man has progressed through some of these others, this does warrant genetic testing. This rate is pretty low, but this was for men who inherited the mutation rather than having it evolve in the tumor itself. So to summarize, we now have many, many more treatments than we used to. I mean, just a few years ago, it was just this one blue bar, docetaxel, was the one medicine we had for castration-resistant prostate cancer that clearly prolonged lives. And now we have a much, much longer list. They are applicable, we are discovering, to the African American population. How we order these things, which we do first, which we do second, what we do, when is one type of medicine prioritized over another, really does vary dramatically from patient to patient. I'm happy to answer questions about that and what some of the considerations are. But now that there are so many options, working closely with your doctor becomes more important than ever. But again, we are fortunate there are medicines available to us now that weren't just a couple of years ago. And as you heard, there are some new ones open around the corner. So I will stop here.
Thank you, Dr. Pomerantz. That was a very detailed presentation on treatments for advanced prostate cancer. And I hope our audience can and appreciate the development over the last few years with the FDA approval of many of these new treatments. I know that when we started FIN back in 2003, that's been a long time, that's 17 years. I think that androgen deprivation therapy and chemo were the two drugs to treat men for advanced prostate cancer. I remember when Proban was approved, and I remember when abiraterone and enzalutamide were approved, and all of these. So it's been an evolution over a relatively short period of time. And I think that goes to point out some of the things that we can look towards in the future. If the rate of development and approval of these drugs continue at this pace, we have a pretty bright future for prostate cancer treatment. And you know, our goal is to make this a chronic disease for all men. I think it's for many men now, it is a chronic disease, just with these therapies that are here. One of the other things that I had to get this in is that a lot of these trials for these new therapies, we advocate strongly for African-American participation in these clinical trials.
I am so glad that you mentioned that, because I wanted to make sure I did before I leave. And I'm going to repeat what you said. I don't think I can say it as eloquently as you just did. It is critical that we have wide enrollments on clinical trials, in particular enrollment among men from underrepresented groups, which include, tragically, given the prevalence in the population, African-American men. It is critical.
And we continue that effort, and we work with many of the pharmaceuticals that developed these therapies in the past, and we will continue to do so and reach out to the patient population to make sure that you're aware of the trial opportunities. Those are treatment options for you. Now, we do have a few questions, Dr. Pomerantz, that I'd like to put forth. One question is, as far as metastatic prostate cancer, are there any results or information about the efficacy of HIFU?
Oh boy. So HIFU is a very localized treatment, and it can be easier to tolerate with fewer side effects compared to radiation. So in theory, if there is a metastatic spot that's causing trouble and needs to be eradicated, HIFU may be an option. We don't have much experience with treating metastatic sites with HIFU, but it is something to consider when radiation is not an option. But of course, like radiation in the setting of metastatic disease, you only kill what you hit. The rest of the disease is left untouched.
Thank you. And another question is, is there a difference between castration treatment and radical prostatectomy?
Yes. So radical prostatectomy means taking out the prostate. And again, that's something that we do when we think that the entirety of the disease is corralled within the prostate. And hormonal therapy, androgen deprivation therapy, chemical castration, they're all synonyms, they're all the same thing. And those are ways of turning off the main source of testosterone, which are the testicles. In the old days, before all of our time, the way that this was done was to surgically remove the testicles. That was the surest way to make sure that most of testosterone production was shut off. And we now have medicines that do the same thing, that are reversible. But chemical castration or surgical castration is focused on testosterone production in the testicles. Radical prostatectomy is taking out the prostate, which has no bearing on testosterone levels.
Thank you. Next question is, how is the topic of genetic testing approached in clinic? Are there differences in opting for genetic testing for African American men versus other men?
It's a really, really good question, and it is very much evolving. And to advocate for yourselves, it is something that you should bring up almost with each visit, or at least once a year, because it really is changing. The current consensus among my colleagues is that all men with metastatic disease across ancestral groups, so it would include our patient we were discussing here, all men with metastatic prostate cancer should get genetic testing. And there are two, we don't have time to go into it here, though I'd love to talk about it sometime to the group. There really are two types of genetics. There's the genetics you inherited from your parents that are in every cell in your body. That's called the germline genome. And there are the genetics of the tumor itself. It's called the somatic genome. And that's the genetics of the tumor itself could be very deranged, mutated, and different than the germline genetics, what you inherited from your parents. And both sets of genetic testing are appropriate now in 2020. This is all relatively new, but are now appropriate for men with metastatic prostate cancer.
What does the current literature say about the influence of vitamin D in prostate cancer?
Well, vitamin D is an important part of our care. All men on hormonal therapy should be taking vitamin D. Vitamin D helps mobilize calcium and build bone. And one of the consequences, one of the side effects of hormonal therapy is that it makes the bones less dense. So vitamin D is a very important part of the daily diet. Vitamin D has been considered in high doses as a form of therapy. And in the Petri dish, it really seemed to work. And several years ago, we were hopeful that it would be an effective form of treatment. Trials didn't bear that out, and it's not something that we routinely do.
Thank you. I have one last question or comment. I was surprised when you indicated that Provenge might be used for men taking chemo, which is usually at a later
during
stage.
During the break.
Okay.
Not during chemo. I'm sorry if I suggested that. Not during chemo.
The other part is, however, Provenge is clearly more effective with men who are in the lowest quartile of PSA. Also, African American men seem to have a better response to Provenge.
That's true, and I didn't mention that is true. That is true. So yeah, we like to give it when we have the disease on the run, when the PSA is low, but we do like to fit it in. Every doctor tries to fit it in different places, but it is something that we do like to include. It takes 6 weeks to deliver, so with some patients it's tough to find the right window.
Dr. Pomerantz, thank you so very much for your presentations and for your answers to these questions. And this information that you provided will be with us for a long time. I know
all right, it's always a pleasure.
And all of your presentations are still with us as part of Fan Television. So thank you so much.
Oh, that's great. Thanks so much.
Okay. relative to